Good afternoon, esteemed colleagues, partners, healthcare professionals, policymakers, and distinguished participants. Welcome. On behalf of the Smiles for Mothers Consortium, in collaboration with Ferring Pharmaceuticals and the Federal Ministry of Health and Social Welfare, I'm delighted to welcome you to this webinar on best practices on the use of heat-stable Carbetocin and other uterotonics for the prevention of postpartum hemorrhage in Nigeria. My name is Chukwuna Osonwokere, and I'm honored to serve as your moderator for today's session. For those of us who may not be familiar with Smiles for Mothers, we are a consortium comprising of HSDF, Solina Center for International Development and Research, CIDA, and Clinton Health Access International, CHI. And we're dedicated to addressing postpartum hemorrhage, which is one of the leading causes of maternal mortality, both globally and here in Nigeria. Over the years, with the general support of MSD for Mothers and now the Gates Foundation, we have collaborated with the Federal Ministry of Health and Social Welfare, Ferring Pharmaceuticals, and other key stakeholders to introduce heat-stable Carbetocin into Nigeria's maternal healthcare landscape. This innovation, which was recommended by the World Health Organization, is a game changer, especially in settings like Nigeria, where the quality of oxytocin cannot always be guaranteed because of power challenges. However, you would agree with me that innovation is not enough. To achieve our ultimate goal of a world where no woman has to die giving life, we also require the correct and effective use of uterotonics, including heat-stable Carbetocin. This webinar is an opportunity to deepen our collective understanding of best practices for heat-stable Carbetocin use, address critical challenges such as the misuse of heat-stable Carbetocin in combination with other uterotonics, and provide a platform for your questions and contributions. Today, I will be joined by Nama Kankun from Smiles for Mothers, Dr. Vishal Shah from Ferring Pharmaceuticals, and Dr. Tunde Amode, who is also from Smiles for Mothers. Following our presentations, there will be time for questions where we would collectively clarify and address any concerns that you may have, and eventually foster a richer understanding of PPH prevention. We aim to make this webinar interactive and engaging as possible. And to kickstart that, we will be putting up a link or a QR code where we want you to participate in a poll to test our collective understanding of the use of uterotonics for PPH prevention. So if you can look on your screen, you will see the QR code. You just scan it to participate in the poll. We'll give a minute or two for that before we proceed with the webinar. You can also access the poll with the link in the chat box if the QR code isn't working. Okay. See, we're getting responses. I see we have 46 participants, but we only have 7 respondents to the first question on the poll. So I would encourage that you participate. Don't be scared. of getting the answers wrong. We will clarify any misconceptions by the end of this webinar. So please feel free to participate in the poll. Okay, so we're getting responses. Please feel free to continue responding, but just tell us what we're seeing so far. So for the first question, we have 22 respondents who responded to the question, what do they use as their first line uterotonic? And the majority say oxytocin. Three people said misoprostol, 4 people said heat-stable carbetocin, nobody saying gometrine. At the end of today, we'll see if this is ideal. Let's move to the next poll question. And I think this one is interesting because it's related to the first on if people would use heat-stable carbetocin as a first line. And here we have 11 or now 12 of 18 respondents saying they would use heat-stable carbetocin, and numbers seem to be increasing, which I guess is good. I think the next question looks at why people might not want to use heat-stable carbetocin as a first line drug for PPH prevention. So we don't seem to have any responses yet. So I'd expect the people who had said no, okay, NA, I'm guessing that's not applicable. Yeah, or not available. So let's try to type out our responses in full price, okay? We'll see if price is really a barrier. It doesn't work. Well, that's an interesting one. On availability of HSC. Okay. Okay. So I'm hoping and I believe that by the end of this webinar, we would see in line with WHO guidance. Okay. So we shall see if these current beliefs are true or not. So at this point, we are meant to move to an opening remark by the Director of Reproductive Health Division, Department of Family Health, the Federal Ministry of Health and Social Welfare here in Nigeria, Dr. Samuel Oyeni. I would hand over to Dr. Samuel Oyeni to give his opening remarks at this point. Dr. Samuel, if you're with us, please go ahead. Dr. Samuel, if you're speaking, your device is muted. Dr. Yeni, if you can hear us, please go ahead with your opening remarks. Okay. It would seem we have some challenges with getting Dr. Oyini on the line. So what we will do is to go ahead with the first presentation in this webinar. And hopefully, when Dr. Oyini rejoins us, we'll then take his remarks. So at this point, I would like to take us to the first presentation, which will be taken by Nama Kankun from Smiles for Mothers Consortium. And he'll be talking to us about a brief overview of postpartum hemorrhage and the use of uterotonics in prevention and treatment of PPH in Nigeria.
Great. Thank you so much, Nonso. And hello, everyone. Thank you for joining our webinar. Really excited to see so many people, but some very familiar names. Thank you for making the time. So over the next few minutes, I'll just be sharing a bit about uterotonics in Nigeria, and some of the slides would respond to some of the comments I saw, things around WHO guidelines, but also its use as a first-line uterotonic. But just to kick us off, postpartum hemorrhages is the #1 cause of maternal mortality in low and middle income countries and is responsible for over 20% of maternal deaths in Nigeria. Globally, Nigeria contributes about 28.5% of maternal deaths, which is very, very high and quite disappointing, if I may say. We have a maternal mortality ratio of about 512 deaths per 100,000 live births. There are also other estimates that put this number as high as over 1,000 per 100,000 live births, and 22% of these deaths are due to PPH. In Nigeria, we know that it's also a significantly leading cause of mortality, and it's sad because PPH can both be prevented and treated, but prevented through active management of the third stage of labor. On the next slide, we see that WHO recommends the use of uterotonics for prevention and treatment of PPH, and they are usually very effective when they are in good quality. So the different uterotonics options are oxytocin, misoprostol, egometrin, and heat-stable carbetocin, which is the newest entrant in this group of medicines. Oxytocin is indicated for both prevention and treatment of PPH, which is the same for misoprostol and egometrin, while heat-stable carbetocin is only currently indicated for prevention, though there are currently studies that are trying to test its efficacy for treatment as well. In terms of storage requirements, we see that oxytocin requires refrigeration, which in our setting can be a challenge. Also needs to be protected from direct sunlight. Misoprostol does not do well in humid conditions, so it needs to be protected from humidity, but also should be stored at ambient temperature. Egometrin also requires cold chain and also does not really do well when exposed to direct sunlight. In low and middle income countries like Nigeria, the widespread poor quality of uterotonics contributes a lot to postpartum hemorrhage. And some of these challenges are due to manufacturing quality, also improper storage conditions, which are very critical for this class of medicines like I just shared. I think it's also important to note that current best practice recommends managing postpartum hemorrhage through a comprehensive bundled approach, which includes uterotonics for prevention, using a calibrated drip for diagnosis, but then also treatment using what's known popularly as the motive bundle. But the focus of this discussion today is really on best practice on uterotonics use. Can we go to the next slide, please? Yes, so speaking to the poor quality, a survey conducted in Nigeria showed that up to 74% of the available oxytocin in the Nigerian market failed quality tests. And oxytocin is actually widely used by over almost 70% of healthcare workers for the prevention of PPH. Misoprostol, which is also an alternative, has its own quality challenges with about 34% of the samples tested that did not meet specifications for the right amount of quality ingredients in the formulation. Poor quality often leads to administration of multiple doses, also just general poor service delivery for women. And due to these challenges, in 2018, following some important and landmark studies, WHO revised its recommendations to include heat-stable carbetocin as an option for preventing PPH, especially in settings where the quality of oxytocin, the gold standard, cannot be guaranteed. And you see from just what I've shared how Nigeria contributes or is a major, has a major potential to benefit from these recommendations. The next slide speaks to some of the economic impacts as well of poor quality uterotonics. So currently, with the poor quality that's available in the market, it costs almost about 73 million annually, beyond the expected health cost for women. And these costs range into things like increased hospital stays, but also buying additional commodities for treatment of the condition of PPH, for example, when it wasn't successfully prevented. The charts on the bars on the right also show you a sense of how much cost savings we could get as a country if this changed. So if quality uterotonics were just widely available, that could lead to cost savings of about 89 million annually. And if all births happened in facilities in Nigeria with quality uterotonics, that significantly increases to about $197 million annually in cost savings. And this work here was important work done by Concept Foundation, which just tried to provide a sense really of the cost of poor quality uterotonics and why it's important that we embrace alternatives or ensure that we have quality in our systems. Next slide, please. So since 2020, the Smiles for Mothers program has collaborated with multiple stakeholders to support the rollout and adoption of WHO recommendations of uterotonics for PPH prevention, and specifically the newest entrant, heat-stable carbetocin. And we did this through, we like to call them 3 journeys: the policy adoption journey, where we supported states and the government to develop costed roadmaps that would lead to the adoption of these recommendations. And we supported policy reviews as well, putting the essential medicines list updates, supporting states to update their training manuals, and working with the supplier to obtain regulatory approval for heat-stable carbetocin in country. On the product end, we also collaborated with the states to incorporate planning for procurement into the annual operational plans, supported training of healthcare workers, also supported states to seed some of these commodities into their drug revolving funds, which then led to sustained procurement over time. Especially, we have some very good case studies in Kano State and Lagos, for example. And then on the patient end, we first had an implementation research which tried to test the acceptability and feasibility of using this product in our setting, but also building capacity through mentoring to ensure that there was some knowledge transfer and healthcare workers could adhere to the use of these commodities. And then lastly, we had patient literacy materials that were distributed to women in communities just to generate demand for health services and also inform them of the suite of services that are available within health facilities in their areas. Next slide, please. So during our work, we also had a chance to check the cost effectiveness of heat-stable carbetocin compared to other uterotonics, and we saw that there is a 2 to 4% difference in cost to the benefit of heat-stable carbetocin per woman when used for PPH prevention. So this just speaks to some of the numbers as well and how it contributes to what I shared earlier about the economic impact. So across different criteria, drug cost, supply chain cost, additional costs that could be incurred due to blood transfusions if you use a poor quality product, we see how ensuring there is heat-stable carbetocin in country and being used widely could then improve the cost implications of care or delivery for a woman in Nigeria. So we really see important potential here for the scale up of this product, especially around the country. So I'll just wrap up quickly on the next slide. So a few things you should take away if you're just joining or you've been here since the start. I think one, poor quality uterotonics contributes significantly to the high maternal mortality ratio in Nigeria. And the widespread availability of these poor products creates an economic burden on the country, especially women who a lot of times have to pay out of pocket for health services. And it will be critical that something is done to address this. And lastly, heat-stable carbetocin presents a promising solution, requires no cold storage, and shows some cost advantages over the available options in country at the moment. And that would then lead to some improved health outcomes for women. Thank you so much for joining. Thank you for listening. I'm looking forward to your questions, if any. Thank you.
Thank you so much, Pharmacist Nama Kankum, for that brilliant presentation. There was so much to take away from there, just, looking at some of the challenges with the different types of uterotonics, looking at how, the poor quality uterotonics that come up from those challenges cost, both the patients and the government a lot of money, and how much money could be potentially saved. I think that point is especially very important when you think about one of the points we saw from the poll about the price. I know we typically think about the cost of heat-stable carbetocin, but we also need to kind of look at the costs, both in terms of what is saved. But I think one thing that is also worth highlighting is that because of the partnership between MSD for Mothers, Ferring Pharmaceuticals, and the WHO, there is actually a public access price heat-stable carbetocin available in the Nigerian markets, carbetocin Ferring, which I think Vishal might touch on when he speaks. Just as we had in the beginning, we have another poll, which should be appearing on your screen shortly. So the question now is, what's your biggest challenge with your current uterotonics? So would you expect you to just type in full, what those challenges are, so that we get a sense of them. For those that are just joining, you can see the link to the poll in the chat box. You can just click on it. I think we can also put up the QR code again, just for easy reference. So we'll just take a minute to take that poll before I call on the next speaker. Okay, so as I said, the link to the poll is in the chat box. You just click on it and quickly respond. We don't seem to be seeing any responses yet. And we would really want to, get your responses so that it also informs what we're telling you during the webinar. That way we can have, good engagement. So I'll just give one more minute for people to respond to the poll before I introduce our next guests. Okay, so I think we're beginning to see some responses. They do not work, so it requires that we buy multiple ampoules of oxytocin. I think this person is referring to oxytocin. Poor efficacy of cold chain, probably still referring to oxytocin. My biggest challenge is that I do not get the required contraction of the uterus. So efficacy issues, refrigeration, poor quality and stockouts, accessibility and affordability are great challenges in my region. Need for multiple doses, lack of storage facilities for oxytocin. All right, so thank you very much. I think a lot of these are quite in line with some of the things Nama had mentioned earlier. But also we have two more speakers that would shed some light on the opportunities that Heat-Stable Carbetocin provides to address a lot of these challenges, but also some other things that we can do in our health system, to address the challenges we face with oxytocin and other uterotonics. So at this point in time, I'll be calling on Dr. Vishal Shah from Ferring, and he'll be talking to us about the recommendations for the use of Heat-Stable Carbetocin and the guideline for practitioners. Welcome, Dr. Shah. Please, over to you.
Yeah, thank you, Chairperson. And yeah, good morning, good afternoon to everyone. May I request for the next slide, please? Yeah. So as my topic has already alluded by my chairperson, it's on the clinical guidelines on the administration of heat-stable carbetocin as a standalone uterotonic for prevention of postpartum hemorrhage. So please, can I go to the next slide, please? And I just want to touch upon initially about the principles of pharmacology, which is based on the pharmacodynamics. And during our MBBS days, we used to study about the basics about the pharmacodynamics. And I thought of giving you three different important definitions based on the pharmacodynamics. First one is the synergistic, where the effect of one drug is enhanced by the other. And, this is something like 2 + 2 is equal to 5, where they act via the different drug receptors. Typically, I would give an example over here since we are discussing about the uterotonics. It's usually the oxytocin and the ergometrin, which will have different mechanism of the action, and that's how it would be a synergistic in the nature. The second one, the definition is additive, in which the interacting drugs will have similar mechanism of the action, and the resultant effect is approximately the same total of the individual drugs. So something similar to like, oxytocin and misoprostol. And intra-additive, in which again, the combined effect of two drugs is smaller than the sum of the individual drugs. And why I'm saying this? Because of the increased adverse effects produced by either one drug or both the drugs. So again, something what has been observed, with oxy and misoprostol. May I request to go on the next slide? With this background, I just want to mention that, we have different uterotonics in our armamentarium that promotes the uterine contractions to prevent the uterine atony, which is the most commonest cause for the postpartum hemorrhage. And we have these different drugs available with us. That's oxytocin, which binds at the oxytocin receptors and stimulates the myometral smooth muscle contraction. We have carbetocin, which also binds to the oxytocin receptors and stimulates the smooth muscle contraction. Then we have ergot alkaloids that basically acts via the calcium channel mechanisms, and that's how the actin myosin interaction, and that's how it produces the myometral contraction. And that's where ergot alkaloids and oxytocin were being introduced, because they would have a synergistic action. However, they have certain contraindications for hypertension, severe hypertension, preeclampsia and eclampsia. And lastly, we have misoprostol, which is a PGE1, and that's how the mechanism of action is there. But again, they increase the myometral contractions. So to revise, these are the different uterotonics which are available, and their mechanism of action, which is very important to understand that how do they promote the uterine contractions to prevent the uterine atony. May I request for the next? Yeah, next slide, please. So with this different drugs available, sorry, the previous, yeah, with this, introduction to the different uterotonics available, I'll be focusing on carbetocin, the heat-stable carbetocin. So heat-stable carbetocin, it's a long-acting synthetic analog of oxytocin. And the benefit is that it's being administered as a single dose injection. It can be given either by the intravenous route or by intramuscular route. The half-life of heat-stable carbetocin when administered IV, it's approximately 40 minutes, which is 4 to 10 times longer than that of a reported of a quality oxytocin. And when you give intramuscular heat-stable carbetocin reaches a peak plasma concentration in less than 30 minutes. And it has a bioavailability of almost around 80%, which is also very good enough, when you give intramuscular. And IV, definitely, since you are giving IV, most of the drug is available in terms of the bioavailability. Next slide, please. This slide is very, very important because when you give intravenous heat-stable carbetocin, it produces a sustained tetanic uterine contractions within 2 minutes. And that's what we want. And it lasts approximately for 6 minutes, this tetanic uterine contractions, and then followed by a rhythmic contractions for approximately 60 minutes. When you give intramuscular, again, the tetanic contraction lasts for around 11 minutes and the rhythmic contraction lasts for around 120 minutes. So we can say that the drug is acting, has a rapid onset of action, which has a tetanic contraction, and then it has a prolonged duration of action. That's the rhythmic contraction for 60 minutes when given by IV route. And when given by intramuscular route, the rhythmic contraction lasts for around 120 minutes. So obviously, the conclusion from this particular slide is that, we have a rapid and a sustained uterine contraction. And the dose which has been proven, the optimal dose of carbetocin, either by intravenous or intramuscular is 100 micrograms. So I think so this slide is very important in terms of the mechanism of action of heat-stable carbetocin. May I request for the next slide, please? My previous speaker already mentioned in his presentation about the quality of the uterotonics, and what I could see in the slide, that was the publication of 2018. While I was just going through some of the references, and I found this publication, which is 2021, and this is a knowledge, attitude, practice of healthcare providers, a descriptive study with the use of quality of oxytocin for the prevention of PPH. So obviously there were a lot of parameters in terms of the quality, in terms of the storage, in terms of induction and augmentation for oxytocin. But I thought of highlighting these important points is that, less than half of the respondents use the WHO recommended dose, that's 10 international units, while the other half of the respondents, they used above the WHO recommended dose, which is more than 10 international units for the prevention of PPH. Over a third of the respondents used the double the dose as per the WHO recommended, that's 20 international units, while a significant proportion used greater than 20 international units. And further, to deep delve down, the further analysis revealed that when oxytocin, was not working for the prevention of PPH, obviously then it comes the management. Most of the respondents were either switched to the another uterotonics, or they were, doubling the dose of oxytocin for their patients. That means they were going to somewhere around 30 or 40 international units. So I think so, from the Menti score, we saw that, the efficacy or the quality of the oxytocin is definitely, maybe one of the concern. But again, that's very much proved in this knowledge, attitude, practice published in 2021. May I request for the next slide, please? So with this particular background, I just wanted to highlight about the Cochrane network meta-analysis, and this was the published data way back in 2018 after the champion study was being published. And the findings from this updated Cochrane network meta-analysis was definitely, to revise the WHO recommendations on uterotonics for PPH prevention. Now, in this study, also the champion study was being included. That was approximately around 30,000 patients. And this was a network meta-analysis where almost 7 different uterotonics were being analyzed. And they were being analyzed on 3 different parameters. One was to look at the amount blood loss, the second one for the need for the additional uterotonics, and the third one was for the safety parameters. May I request for the next slide, please? And if you see the outcome of this particular Cochrane network meta-analysis, as you can see in this particular slide, heat-stable carbetocin is the highest ranked single uterotonic agent for the prevention of more than or equal to blood loss of 500 ml. Whereas definitely you can say oxytocin, misoprostol, or ergometrin, they are there, but then again, it's the combination which has been shown. But overall, carbetocin as a single agent prevents the blood loss of more than or equal to 500 ml. And if you see alone oxytocin, it does not come into the first three. In terms for the need for the additional uterotonic agents, if you can just go to the next slide, please. Again, overall, if you go to see heat-stable carbetocin as a single agent, again, it ranks almost top in compared to the other uterotonic agents for the need for the additional uterotonics compared to all other 6 or 7, uterotonics. May I request to go on the next slide, please? So overall, in terms of the efficacy, we can say that heat-stable carbetocin as a single agent, as a single agent prevents the blood loss of more than or equal to 500 ml. And as the need for the additional uterotonic as a single agent, it reduces the need for the other additional uterotonics. Now, in terms of the safety parameters, as you can see over here, heat-stable carbetocin and oxytocin have a comparable safety profile. But overall, if you go to see again, look at the in the bottom, you can see if you see misoprostol plus oxytocin, in terms of the fever, it's more than 1. If you see again nausea, when you compare misoprostol plus carbetocin, again, it's more than 1 in comparison to carbetocin. Shivering, yeah, again, it's again more pronounced again in comparison to that of carbetocin. And obviously, when you see the vomiting also, again, misoprostol plus oxytocin, again, it scores more than 1. So overall, we can say that, heat-stable carbetocin has a similar safety profile in comparison to oxytocin, but the other drugs which are being used as a combination, they have a more adverse effects in terms of, nausea, fever, shivering, and vomiting. And maybe because of these kind of side effects, there might be a probability of less maternal, what you can say, bonding. Probably also there could be chances of, the feeding may also become, breastfeeding may become also less because of this side effects or the adverse reactions. May I request for the next slide, please? So based on this network meta-analysis, WHO had revised their guidelines in 2018, and they had recommended now heat-stable carbetocin for the prevention of PPH only, and the dosage which was being used was 100 microgram either by intramuscular route or intravenous route, and for the prevention of PPH for all the births. May I request for the next slide, please? Also, the FIGO ICM recommendations, that's the International Confederation of Midwives, they had also, this was published in 2022, and they had also mentioned that where in settings where oxytocin is unavailable or its quality cannot be guaranteed, then heat-stable carbetocin 100 microgram either by intramuscular or intravenous route is the recommended for the prevention of PPH. But the another important point which I would like to highlight over here, it's about the combination what they are saying. And you can see obviously ergometrin plus oxytocin or misoprostol plus oxytocin definitely there would be a effective uterotonic drug strategies, but at the expense of high risk of the adverse events which we saw in the previous slides, like vomiting and hypertension. May I request for the next slide, please? Just to add and to validate, we saw two guidelines. One was the WHO and the second one was FIGO ICM. The third important guidelines, which I would like to again focus, is the International Consensus 2019 by the group of the anesthesiologists. And they have recommended carbetocin. It's a longer acting analog. May I request for the next, if you can just click. It has shown that carbetocin is the preferred drug, first line drug, rather than oxytocin for the prevention of PPH during the cesarean section. And the anesthesiologists, I would say, are well advanced, much forward. They've already said that in their recommendation that heat-stable carbetocin becomes the first line of the drug for the prevention of postpartum hemorrhage during the cesarean section. May I request for the next slide, please? So to summarize, you can just click, please. Just to summarize, heat-stable carbetocin, it's the WHO recommended by WHO, FIGO, ICM, as well as the Anesthesiology Society for the prevention of PPH. And it's also being listed in the WHO's essential medicine list. I just wanted to again re-emphasize that drug has an initial tetanic followed by a rhythmic contraction, and also it has a longer duration of uterine activity than oxytocin. It's being proven by the network meta-analysis that it's for the prevention of PPH as a single agent. And obviously, one of the important points which I would like to highlight, should not be used during the pregnancy or before the birth of the baby because of longer duration of action. It's the only injectable uterotonic that can be stored in the approved storage condition, that's at 30 degrees centigrade, for a shelf life we have for 4 years. Only one dose is sufficient for all the kinds of births, that's vaginal delivery and the cesarean section. And the network meta-analysis which we saw, which was being compared with 6 other uterotonic agents, favors heat-stable carbetocin as a single agent. And lastly, as my previous speaker already mentioned, this is a cost effective, but I would also like to highlight over here that the drug is a heat stable drug. So definitely it becomes a preferred choice for the prevention of postpartum hemorrhage. With this, I would like to conclude, and thanks a lot.
Thank you so much. Thank you so much, Dr. Vishal Shah. I think that was a very brilliant presentation. I wish we could actually give you a round of applause for that. I noted a few things here on how heat-stable carbetocin has a rapid onset and it's long-lasting, and therefore making it ideal for the prevention of PPH during the third stage of labor. How it comes highly recommended by WHO, FIGO, ICM, and the anesthesiology organization. Also, I think one very important thing to highlight, especially considering that even from the polls and even some of the research you pointed out, there's already a practice of combining uterotonics, with the fact that heat-stable carbetocin is efficacious as a single agent, so there's no need to combine it with other uterotonics. And I think Dr. Tunde Amode will speak a bit more on that shortly. It's also a very safe drug, and it's recommended for PPH prevention only as of today, and can be used for all types of deliveries. I understand that Dr. Samuel Yeni is now with us. So we were supposed to take his opening remarks earlier, so I'll call on him now to take his remarks before we take another poll and also address some of the questions that we're seeing in the Q&A section. So Dr. Samuel Yeni, please go ahead and give us your opening remarks if you can hear us.
Thank you also for the privilege that you have given us. Sorry, the network where I am, the network is not very good. So I've been on and off. But actually, I want to appreciate the organizer of this webinar. It's something we should do often, regularly, so moving forward. And I also want to appreciate all those people that have come, that have joined this webinar, all the partners in the PPH care space, for all we've been able to achieve this last year till now. I just want to implore us that we should follow the guidelines in our implementation. We should follow the training manuals and ensure that we train the appropriate people at the facility. We are very focused on this. The people that are doing the real delivery in the maternity should be prioritized. And please, we want us to follow the SOP that we all agree to, and to remind us of, as we implement down the states, we have all agreed that we are going to do advocacy. And advocacy should not just be on PPH. We should look at reduction of maternal mortality as a whole before we now come down to talk about PPH rollout or PPH care during the advocacy. And it should be a joint and holistic participation in all the partners that are in the state working on one thing or the other, and the partners that are supporting on PPH care in the state. So please, let's ensure that this is done as we roll out. It's something we need to move fast. We need to combat PPH in Nigeria. It's the highest contributor to maternal mortality in Nigeria. So if we look at the emotive, early detection is the thing, but how can we detect early if we don't use calibrated drain? We are moving fast on that also. And the use of that calibrated drain, we should also be finding a way of talking about it during the advocacy. How can we engage health workers? How can we demonstrate the use of calibrated drain? I remember during the Sogon conference in Rio, I was informed a lot of consultants are still asking to demonstrate the use of calibrated drain, to let you know the importance of taking this awareness down to the facility. If at Sogon conference, people are still transparent, will I say honest enough, that it should be demonstrated, they want to see it, the use, how much more the nurse or the midwives in the facility, in the maternity. So I think now, where we are now, the next thing is how can we carry the use of calibrated drain to the maternity ward of all the facilities in Nigeria, both private and public. Now, I'm very glad with all the presentation that has been done. Heat-Stable Carbetocin is seriously welcome. We have included it in our strategy and in all the documents, in our LSS training manual, the PPH training manual. So that is already done. But I also saw something on the presentation in terms of the costs. How can we still bring the cost further down? How can we assess Heat-Stable Carbetocin for use so that it will reduce the out of stock and people can appreciate its action and be able to continue to use? These are the things that we need to, and to maintain the efficacy. A lot of people have submitted most of the problem with oxytocin or uterotonics. The challenge is the efficacy. How can we continue to maintain the efficacy of uterotonics? I remember when we started with misoprostol, but now a lot of complaint about its efficacy. How can we prevent such happening to heat-stable carbetocin? And these are the things we need to bring on the table. If we need to have a round table with all the agencies involved. How can we do this so that heat-stable carbetocin will not also go the same way misoprostol went, the same way oxytocin also. So these are the things we need to be thinking about to get this done together. Government cannot do it alone, we all know. So it's going to be a collaborative effort to maintain the efficacy of uterotonics in Nigeria. So we need to think about this. So once again, on behalf of the Federal Ministry of Health and Social Welfare, the coordinating minister, we appreciate all the effort all the partners are putting into PPH care to reduce maternal mortality. And please, we still need more effort, more support, especially than the state, than the local government, than the community, to make sure that this is reduced. Before I go, on our side, we want to take this further. We want to see how we can prioritize high impact practices along with what we are rolling out. Postpartum family planning needs to come in now. As we roll out PPH, there is a need to cap it with postpartum family planning. Once PPH is diagnosed, the patient that has PPH should be encouraged, should have family planning before leaving the facility, should be counseled on it. And not only PPH, we want to go to all the maternal health complications, eclampsia, pre-eclampsia. We want to go on to maternal mental health and be able to see how we can integrate family planning to MSCH, going further, so that we can directly use FP to be able to have the impact in the reduction of maternal mortality. For patients that have such high risk delivered and it's not on FP, you can come back within few months and be pregnant again. Then the risk will be doubled and may even die from there. So this we talked at the FP conference. There is a need to integrate FP into MNCH. Now that we are rolling out, we need to collaborate with FP coordinators at the state level to make sure that all those that are diagnosed as having PPH must be counseled and given FP before leaving facility as high impact practice. So we'll be reaching out on this very soon. So thank you. I wish us a very fruitful deliberation in the webinar. Thank you very much for bringing us into this. I want to thank Smile for Mothers for leading this process. Thank you very much. Over.
Thank you very much, Dr. Yeni. As always, coming with the insights from a leadership perspective. I think Dr. Yeni has reminded us of some of the broader conversations that need to be had, even though we're talking about PPH prevention today. Conversations about emotive, conversations about maternal deaths, conversations about integrated maternal health, postpartum family planning and the likes. I think it's also very interesting, the points you raised about, the fact that knowledge gaps still even exist at the highest levels and even, things that have changed around the price. But most importantly, reminding us that, to overcome PPH and maternal deaths as a whole, it's a collaboration between government, partners, communities, and, various stakeholders. So I think those are really very important words for us to all reflect on. So after taking the first two presentations, I would want to take some time to answer some questions. If you're looking for where the questions are, at the bottom of your screen, you'll see the Q&A icon. You can click on them to see the questions that have been asked so far. Most of them have actually been responded to by my presenters, but I would take one that hasn't been answered and still allow my presenters, add any additional context they might want to add to some they've responded to. So the first one, which I think will go to Nama, is from an anonymous attendee, and here I think he or she is asking about how the Smarts for Mothers Consortium is supporting government and addressing some other barriers like poor cold chain and storage infrastructure to access quality assured oxytocin, which is recommended for PPH treatment, since Heat-Stable Carbetocin is limited to just prevention. So I'll hand over at this point to Nama to take that question.
Right, thank you so much, Nonso, and thank you for the question. So the answer is yes. Our project made efforts to address the supply chain challenges, especially relating to the cold chain for oxytocin. We also intervened on the regulatory pharmacovigilance end as well. For the cold chain, we explored leveraging the established oxytocin cold chain for cold storage of uterotonics, including oxytocin specifically. I think we had some success in one of our focus states where at the central store level, stakeholders were able to take oxytocin that they had and they have enough cold chain for to store within the vaccine cold stores. And so that sort of left that integrity in place. And so just based on those case studies, we took up that conversation with the National Primary Healthcare Development Agency. And I think early last year, they welcomed the idea and promised to take it up within their leadership to discuss how that would look like on the national level. So it's something that would still follow up on to see how the lessons or evidence from one of our states can influence national scale-up and adoption. And for the regulatory end as well, part of our capacity building for pharmacists and technicians, also even the clinicians themselves, included pharmacovigilance. So we supported them to ensure they could report poor quality products, provided technical support to document the reports when necessary, whenever there was poor quality, and ensure that these were submitted to NAFDAC. Unfortunately, we were not able to directly engage or provide any assistance to NAFDAC specifically, but we also know that that agency has been making some efforts to address some of these quality challenges. So thank you. That's the response. Over.
Fantastic. Thank you very much, Nama. Vishal, I see you've responded to a bunch of questions, in the Q&A section, questions around the contraindications of, Heat-Stable Carbetocin, on whether it could be used for inducing delivery. I know you also kind of touched on it when you talked about the pharmacology of Heat-Stable Carbetocin, which probably addresses some of these questions. But I think it would be good to give you some time to just provide a bit more detail to some of these responses that you provided. Over to you, Vishal.
Yeah, so thanks a lot once again. So the questions, I think so more importantly, which again, I would like to re-emphasize, is about the contraindications of heat-stable carbetocin. It's contraindicated for induction as well as for the augmentation of the labor. And the reason for this contraindication, if you see at the pharmacology of heat-stable carbetocin, it has a longer duration of the action. And because of its longer duration of the action, it's clear-cut contraindication. Otherwise, there could be a fetal asphyxia or a fetal demise. But apart from that, there are certain other important contraindications which are similar to that of oxytocin, because it's an analog of oxytocin, like a severe cardiovascular disease or a severe renal or hepatic disorders. And even epilepsy, it's a clear-cut contraindication. So these are some of the important contraindication. One of the question was, the side effects. Obviously, yeah, all your drugs would have side effects. Obviously, this is not like a silver bullet, but yeah, what has been observed in the clinical practice as well as based on the evidences, that heat stable carbetocin does have side effects which are minor in nature, and these are mostly like gastrointestinal side effects, like abdominal pain sometimes, or sometimes there could be nausea, or a diarrhea. So these are some of the commonest adverse effects which has been observed. And very importantly, as I mentioned, again, I'm repeating, since the mechanism of action, it's both technique in the nature and rhythmic in the nature. Hence, there is no need to add any other uterotonics, like misoprostol or any other uterotonic. So hence, heat stable carbetocin, could be needs to be used as a single uterotonic agent for the prevention of postpartum hemorrhage. And secondly, I was just looking at a lot of other references and evidences, but even after this network meta-analysis, there are not any studies which has been published, of this combination. So hence the evidence is not available. So, and plus heat stable carbetocin as a single agent has been proven in this network meta-analysis, which is including more than 190,000 patients. So overall, I would conclude that, whatever the questions were being asked, I hope, I'm being able to give a satisfactory answers. And it's a drug which is just a single agent, and also it's a heat stable product. Thank you.
All right. Thank you very much, Vishal, for those. And thank you all for your questions. I see there was a question from Yahya Alamin Ibrahim on whether heat-stable carbetocin can be used for blood loss in road traffic accidents and other cases of hemorrhage. So the answer to that is no, just considering the
Absolutely.
mechanism of action of heat-stable carbetocin as a uterotonic, which is really causing contraction of the uterus. So unlike other hemorrhage management drugs like TXA, tranexamic acid, uterotonics do not work by affecting clotting factors or other mechanisms. So the short answer to your question is no, it does not. So I'm going to call on our next speaker. That's Dr. Tunde Amode, who is also from the Smiles for Mothers Consortium. Tunde, before you go into your presentation, I see you had initially responded to a question from Adebayo Adekunle from Lagos State University Teaching Hospital. So if there's any additional information you want to provide, I think you can do that before then going into your presentation, which is on examining the practice of combining heat-stable carbetocin with misoprostol, separating facts from practice. So Tunde, over to you and welcome.
Thank you very much, Nonso. Good day, everyone. I think I'll just explain a little how previous PPH could contribute, or having a uterine. Let me talk to the uterine scar. So for previous surgery on the uterus, the mere fact that you have made an incision, either single or multiple, on the uterine wall will result into disruption of the alignment of the myometrial fibers. So as we all are aware, the contraction in the uterus follows a certain pattern. So that is disrupted during labor. And because of the fibrous tissue also generated, also means that in some cases, you will have hyperplacentation, which will result in placenta growing towards the lower uterine segment and at times covering the internal os. All these constitute and work together to increase the risk for PPH. Now, the fibrous tissue and the weakening of the uterine wall can also, of course, lead to rupture of the uterus during contraction, particularly if you have tetanic contraction. So all these mechanisms working together increases the risk of PPH in the subsequent pregnancy when there is a uterine surgery. And for the risk, whether primary innate causes or secondary causes that are still existing, once there is a PPH incidence in a woman, findings over time is that in subsequent pregnancy, there is increased risk of PPH also occurring. So at times up to 3 or more fold. So that's, I think, is the message that once there is an injury to the uterus through surgery or there's previous history of PPH, there is likelihood that the PPH will occur in subsequent pregnancy. So these are cases that are taken as high risk and with the need for more surveillance and to ensure that PPH is prevented. So I'll go into my presentation now. Can we kindly move to the next slide? Thank you very much. So as Nonso said, and the first presenter, Nama, the Smart Mothers Program has been working in collaboration with the Federal Ministry of Health, as well as the states governments in Kano, Niger, and Lagos to introduce Heat-Stable Carbetocin for use for PPH prevention as recommended by the WHO in its 2018 recommendation for PPH prevention. And so as a program, we had helped to support the introduction of other innovations. And one of them was the introduction of HSC for use, that's Heat-Stable Carbetocin, for preventing PPH. This was facilitated by the donation of a seed stock for use in facilities across implementation states. In addition to this, we did also have an implementation research that was conducted. The link to the published paper is below and on the chat box. So overall, we looked to generate evidence that for the safe and effective use of uterotonics for prevention as well as treatment of postpartum hemorrhage. Specifically, we looked to assess what the current practice was then. This study was, the data for this study was collected in 2022, and the paper was published in 2024. We also look to investigate the acceptability of Heat-Stable Carbetocin following its introduction to clinicians providing active management of third stage of labor to women delivering. And we liked to look at and understand what were the factors that enabled the appropriate and rational use of uterotonics for PPH prevention. So the availability of HSC made this possible, and this was added to the mix of all the other uterotonics, oxytocin, misoprostol, and egometrin in some cases. And our findings were that overall, for a clinician to make the decision to use a particular uterotonic, it depends on both pre-service and in-service learnings. And that, of course, we found that the availability of reading materials with this content was very instrumental to what, or instructional to what uterotonic will use. So job aids were provided that, I guess, if they were in textbooks, that will also work. Guidance by senior colleagues, attending workshops, and having mentorship was also contributory to this. And so after deciding to use this, we also looked at what particularly was the pattern and the trend for use. So in a cohort of 1,024 women, we found that at least one uterotonic was administered for PPH prevention. And in some cases, 2 or more were administered. When we looked at the pattern of administration of uterotonics, HSC took the bulk of what was administered at 60%. And we also looked at the doses that were administered. You remember that Dr. Vishad had mentioned that with the studies have found that oxytocin over time, there has been increase in doses administered to women for prevention of PPH. So we also found the same, that so in some cases, oxytocin was administered above the 10 units as recommended by the WHO. And when we looked at how acceptable HSC was to provide, and now that they have had the experience of using it for PPH prevention, 76%, a very high number, so to say, said they did prefer it as the uterotonic of choice. But they were very happy that at least there was something being added. So we had 97% looking at that HSC is now available in the mix of uterotonics for PPH management. And 94% showed willingness to continue to use it to ensure that we have adequate care to prevent PPH. Now, what contributed to their decisions as to accepting HSC? The safety profile, as Richard also said, was very critical to this, and its efficacy and that of cost. I think Nama had talked about cost and the changes over time. Kindly let us move to the next slide. So as follow-up to this, in 2024, we also did conduct an assessment to then look at 2 years after the introduction, what currently was the practice, what was the knowledge around HSC and its use for PPH prevention. So our finding was that more clinicians were now aware that HSC was available and can be used to prevent PPH. So that's why we have familiarity of 90% of those assessed. They were very familiar, they were using it in their practice, and they were willing to also recommend to other clinicians for use in preventing PPH. And we further did ask them that what exactly were the issues around the use of HSC and what they envisage could be barriers to scaling up throughout the country the use of HSC, which is effective for preventing PPH. Their first response was that it was cost that they looked at, and cost was a major one. The availability of HSC itself was, and then of course people not being aware. So for the solution, they were looking at lowering the costs and improving availability, making it very accessible for your healthcare workers to use. And of course, training, education, passing knowledge to healthcare workers on availability and how it is to be used were the major strategy that they think will improve the use or increase the use of carbetocin for PPH prevention. Next slide, please. So now we then looked at what the practice was around HSC, that's carbetocin use with misoprostol. It was, of course, a common practice of oxytocin being administered with misoprostol. So now we looked at what was happening around carbetocin. And the question around, as the clinician combined carbetocin with misoprostol, we did get a high response. We got almost 70% say at one time or the other, they have combined carbetocin with misoprostol in the management of PPH. When we looked at indications for this use, PPH treatment took the bulk of what this combination was used for. It did make sense because no clinician will really want to look at a woman bleed torrentially and then go out to tell the story of being sorry, we couldn't do anything. So it made sense that they were combining carbetocin with misoprostol. But then I also need to call attention to the fact that the WHO recommendation for the use of carbetocin was for PPH prevention. It's yet to be approved for treatment. But the human we have, we really will want to do everything to ensure that we do save a life anytime we are faced with that challenge. Now, it was also administered prophylactically to prevention of PPH in high-risk women. So as Adebayo had asked, women with previous surgery, maybe with enlarged uterus, multiple gestation, previous history of PPH. They did get the uterotonic administered prophylactically. Now, for the routine use, we then had respondents that said they were already combining it for routine use. And of course, that may be linked to the previous practice of using oxytocin, which over time had been found to have various versions that were substandard and suboptimal in the response in preventing PPH. And so why we then asked them why and for what reason why they're combining carbetocin with misoprostol. The first response, of course, was to enhance efficacy, which in essence would be a suggestion that there will be synergy in when you administer the two together. I think Richard told us that doesn't happen really. And of course, for patient-specific factors, which will lead to or can be linked to high-risk cases. And the quality of medication was also part of the concern. And so I would summarize the two studies that has been conducted and what we've synthesized from our findings. So please, let's go to the next slide. So far, what we can say is happening is that as a carryover of the practice of oxytocin being combined with misoprostol, carbetocin, we're seeing the combination of it also being combined with misoprostol, maybe as it is taken as a substitute for oxytocin. It is an analog, so it's also maybe the reason. There is also still misgiving about the quality of medication and the desire to, of course, prevent PPH altogether add to the use of multiple medication, in this case, carbetocin as well as oxytocin. And lastly, that strong conviction that HSC alone can prevent PPH is also part of why we're seeing this practice of combining the two medications. So finally, I would like to conclude the next slide, that carbetocin alone has been proven to be highly effective. And not only that, the safety profile is good. And we also know that it is cost efficient, even though currently it's going for 1,006 per ampoule, but it is just that ampoule that you are going to use. So it is effective as a single dose uterotonic option in the low, middle, and income country. This has been proven successfully in countries, not only in Nigeria. We've had this in Kenya, Ethiopia, Uganda, Sierra Leone, Senegal, where studies and implementation had also shown that carbetocin can be used for PPH prevention. And then finally, we also know that over the long run, it is more cost effective, because then you have to consider issues around cold chain requirements, the need for transfusion, the need to provide additional uterotonics when PPH do occur. Not only that, but even when we think about the electricity bill, although of course there are other products that will be using the cold chain infrastructure, the electricity bill alone of keeping oxytocin in the cold chain may in some area support the use of carbetocin, as it can stay on the shelf in a cool environment. So thank you very much now for listening in. I'll hand over to Nonso, then we can attend to more questions if you have. Hi, Nonso, over to you.
Great. Thank you very much, Dr. Tunde, for that, sharing, the insights from the Smarts for Mothers implementation research and also the survey. As we said in the beginning, the innovation that is heat-stable carbetocin by itself is not enough. It has to be used in the right and correct way, which I think is the major thrust of the presentation you just made, and also part of what Vishal shared with us earlier. So again, we're open for questions. I see there's already a question from Jamila Sidin Kanu. and maybe I'll just read it out while you get ready to respond. And please, everybody else, just feel free to use the Q&A icon to type up your questions. So Jamila's question goes thus. We all know that maternal mortality is a big life threatening situation to our community. We shall be a bit of Carbetocin in our pharmacy and clinic nationwide, and training needs to be done to the staff involved. So I think it's more of a comment, and maybe I can provide an initial response to it. Yeah, right. So thanks a lot, Jamila. So Heat-Stable Carbetocin, specifically Carbetocin Ferring, which is the public access price version of Heat-Stable Carbetocin, is available in a few states in Nigeria as of today, specifically Kano, Lagos, and Niger. It's available in all the secondary health facilities and a good number of primary healthcare facilities through the Kano DMCSA, where it can be procured. So if you are not yet having Heat-Stable Carbetocin in your facility, please feel free to reach out to us. I think we'll drop an email address in the chat box, and we can explore further how we link you to Heat-Stable Carbetocin. That said, there is a supply of Heat-Stable Carbetocin in the country who is ready to supply to any states that is interested in procuring it. We're also able to provide that information. So anybody looking to procure Heat-Stable Carbetocin anywhere in Nigeria, can reach out to us, and we'll link them to Ferring's representative in Nigeria. I see that Dr. Samuel Oyeni has his hand up. I think I'll just let him respond or make his comments. Dr. Oyeni.
Thank you very much. We would like to have those contacts where people can get Heat-Stable Carbetocin. I want to find out if there's any in the South. The approach we used for the calibrated drip, we have one manufacturer in Ibadan, one in Kano also. So what we did is Federal Ministry of Health, signed by the Minister or PAMSEC, sent letter to all the ministries in the 36 plus FCT on calibrated drip, the use of it, and where they can get them to buy. As I'm talking to you, a lot of states have put it in their budget last year that they can now buy calibrated drip this year from the state budgets. So the same vein, please kindly either write to the ministry. I know that letter will get to me. Then we can send this letter to all the states of the Federation on the use of Heat-Stable Carbetocin. They are already aware of it during the PPH training, both the national training that occur in both South and North. So the awareness is already moving on. But if they know where they can get it, the states can begin to put their together to purchase on their own, just like they are doing for calibrated drip now. So that's just what I want to say with that information before I forget. We'll discuss others later as we go on in the process. Thank you.
All right. Thank you. Thank you very much, Dr. Yeni, for that. Yeah, so we've noted that down, and we will share the contacts of IDA Foundation so that the Federal Ministry could help us, disseminate that to the states. So we will act on that. I see a bunch of questions. Some I'll be able to answer, some I'll pass along to my presenters. So there's a question from an anonymous attendee about what the Smiles for Mothers Consortium is putting in place to discourage combination of Heat-Stable Carbetocin with misoprostol. I think the first answer is that is actually the basis for this webinar, which is the first of several series about PPH prevention and treatment. So we are hoping to use this webinar and other media to pass across the right information. We're also hoping to leverage some of the upcoming healthcare worker trainings to emphasize that. So that's what we are trying to do about the wrongful combination of heat-stable carbetocin and misoprostol that we are beginning to observe. How much is carbetocin in Naira? As of today, the average price in the states where the public access carbetocin Ferring is available is 1,600 Naira. So that's the price patients pay for it, which of course includes the respective markups that the state's drug management agencies have included to the products. There's a question on if carbetocin is safe for preeclampsia patients. I think I would let Tunde answer that shortly. Let me just see if there are any other questions on how I want to distribute them. How do you make heat-stable carbetocin available to private facilities? I think Vishal will be able to answer that. I know as of today, the public access price formulation is available for just public facilities, but I'm sure colleagues from Ferring probably have a vision for how to get to the private facility. So Vishal, just be on standby. And again, a question on if heat-stable carbetocin can be used to induce labor. I see Tunde is already typing a response, but I think Vishal had answered a similar question earlier, which the answer was it cannot be used to induce labor because of its pharmacological characteristics. So Tunde, if you could help us answer the question on carbetocin safety for preeclampsia, and then thereafter, Vishal, you could take the question on availability for private facilities. Tunde, over to you.
All right, thank you very much. Carbetocin is safe for use in preeclamptic patients, and this is just the same way oxytocin is safe for use. So unlike ergometrin that causes increase in blood pressure, carbetocin doesn't do this. So it is safe for use in the preeclamptic and eclamptic patients. I'll also talk to the the use for induction of labor. So it is contraindicated, and that's a capital NO in the induction as well as in augmentation of labor, even though we do say it, or even though it is an oxytocin analog, but the mechanism of action of the initial contractile effect it has on the uterus will lead to asphyxiation of the baby. So because of that, it is contraindicated for induction as well as augmentation of labor, just prevention of PPH.
Great, thank you. Vishal, over to you. Availability of HSC for private facilities.
Yeah, so I'm sure carbetocin, heat-stable carbetocin or Pabal, it's available in the private facilities. Obviously, and we have this carbetocin Ferring, which is meant only for the public facilities. So overall, we have this commitment to the WHO that heat-stable carbetocin, which is available in the form of the ampule, it's only meant for the public market. And we have another form that's in the form of the vials, and this vial is definitely available in the private market. So I think so that's how the differentiation of what's available. So overall, the drug is available for the private facilities. That's by the brand name, which is called as Pabal. Thank you.
All right, thank you so much, Vishal. I noted that during the course of our webinar, we had a peak number of participants of 107. On behalf of the Smiles for Mothers Consortium, I really want to thank all 107 of you for your participation, for your engagement. And I also want to thank my presenters for their brilliant presentations and responses to all the questions. I think a few things for us to just take away from all the conversations today as follows. First is, as we talk about postpartum hemorrhage, let's remember some of the broader conversations that go beyond postpartum hemorrhage prevention. You know, there's treatment, which is emotive. We also need to be mindful of the other causes of maternal deaths. And I believe this is why for us at Smiles for Mothers, we're looking at this webinar as a first of series targeted at postpartum hemorrhage, but hopefully that those might then evolve to broader maternal health conversations. So please be on the lookout for our subsequent webinars. We also went through some of the challenges that different uterotonics face and why heat-stable carbetocin provides a viable option, especially in our environment, to provide efficacious and cost-effective prevention of postpartum hemorrhage, especially when you consider its pharmacological characteristics. I think we also, looked at some of the unfortunate wrongful practices when it comes to the use of heat-stable carbetocin, and we've been reassured that all the evidence and experience shows that heat-stable carbetocin is efficacious as a single uterotonic agent. So on behalf of the Smiles for Mothers Consortium, Ferring Pharmaceuticals, and the Federal Ministry of Health and Social Welfare, I really want to thank and appreciate everyone who participated in today's webinar, and we look forward to seeing you again. Please be on the lookout for further communications from us, where we would also share some of our knowledge, products, and resources. We would also want to use this opportunity to share with you our latest knowledge products, which is Year 3 brief. The QR code is on the screen, and you can scan it, download it, read it, and see what we were able to achieve in the last 1 year. And you can also reach out to us through the email addresses that have been provided in the chat box. So once again, thank you and have a lovely day. And if you can still stay on, we have a final poll question, which is on your screen. You can participate. And let's see if we've been able to change some minds from earlier. Thank you and have a lovely day.